This echocardiography involves a 19-year-old teenager with a history of aortic valve replacement (AVR) 10 years ago due to bicuspid aortic valve. Unfortunately, sudden ascending aortopathy was overlooked during the preoperative evaluation, and several years later, severe dilation of the ascending aorta became an issue. The patient was admitted to the hospital due to dyspnea and pulmonary congestion, and the echocardiography revealed significant pulmonary hypertension. As you know, the major complications of a thoracic aortic aneurysm include aortic rupture and dissection. Here we have a short axis view of ascending aorta, which is severely dilated and is pushing the main pulmonary artery away. However, we can observe an abnormal continuous flow at the junction of the aorta and the main pulmonary artery. This short axis view enhanced with contrast shows an abnormal area of negative contrast in the main pulmonary artery. Indeed, a rare complication of aortic aneurysm has occurred, an aortopulmonary fistula, which creates an acute left-right shunt. This fistula is responsible for the decompensated heart function, pulmonary congestion, and postcapillary pulmonary hypertension. In fact, when agitated saline was injected, the contrast in the pulmonary artery was washed out by the shunt flow from that aortic fistula. However, some bubbles were also visible in the aorta, indicative of a small right to left shunt. The patient was scheduled for surgery, but unfortunately, he suffered a cardiac arrest to death before the procedure. This case highlights the importance of thoroughly assessing for aortopathy in every patient who is a candidate for aortic valve surgery. Some clues of concomitant aortopathy in patients with a bicuspid aortic valve include dilated aortic root or ascending aorta, or even disproportionate size of aorta to age, body surface area, or aortic valve disease. Abnormal aortic geometry, such as eccentric aortic dilation, loss of sinotubular junction indentation, or an elongated ascending aorta is also significant. A rapid increase in aortic diameter of more than 0.3 cm per year and an indexed aortic size of more than 10 square centimeters per meter, it means cross-sectional area of aorta relative to the patient's height as also key signs. Finally, a family history of aortic dissection is an important factor to consider.